Hello, everybody, and welcome to one of the last full panels of the day. I know that you are very much ready to go and have a glass of wine and relax for the rest of the evening, but we have a very exciting panel for you today, and I'm very pleased to introduce two very esteemed panelists, Dr. Belinda Najai. Dr. Najai is a associate professor in cancer biomarkers and epigenetics, and director of the Molecular Epidemiology Laboratory at the Wolfson Center of Population Health. And Dr. Elizabeth Adams. Elizabeth is the managing director and founder of Aquarius Population Health. So I ask you to welcome these two esteemed panelists to the stage. You will find their bios and also mine in our on the conference website. So I'm going to tell you there's going to be a couple of objectives to this panel today. They are to discuss how non-invasive sample collection can support better diversity, equity, and inclusion in healthcare, to gain an appreciation for first void urine as an alternative to samples collected by clinicians, including clinical research outcomes and patient preferences. And finally, to understand the impact of self-collected first void urine as compared to sample collected by clinicians at geographic scale, including the cost of care. So we will begin by just discussing how serious this problem is. We have a tool that we'll be talking about today, but the tool is only part of the solution. The real solution is getting access to women who are dying, who don't have access to the tools that they need to make informed decisions about their health for something that we can actually treat and keep them alive. So there's an estimated 9.5 million missed cancer screenings annually. And since COVID-19, there's been a 94% drop in cervical cancer screenings. HPV is related to more than 99% of cervical cancer cases. Half of the cases are among women who have never, ever been screened. And that's sad for us to say in the healthcare industry. Black women, like me, have the second highest incidence and the highest mortality rates from cervical cancers caused by HPV. And despite everything that we've done around Pap testing, disparities in cervical cancer remain very high, and the mortality rates by race are persistent and have not been changed for decades, given limited access to screening. So it's time that we found a way to use the tools to come up with better solutions than we've been using in the past. And ladies, Belinda, we would love for you to talk a little bit about ColiP and the tool itself.
Thank you, Deborah, and welcome everyone. So ColiP particularly, I think this is a very useful tool, and there are several reasons. This is a patented device, actually, and why is it so good in collecting the right sample? It's because you collect the first void urine, which is the part that is enriched with shedded cells in there. And that's why if you can collect that part, which is the first part of the urine, then you can perform any molecular test down the line, downstream. And I've been using it in my lab. I've been performing several clinical trials as well. And we developed a DNA methylation marker test, actually, that works very well with a sample collected with ColiP. But we also do HPV DNA testing and microbiome analysis. So it's quite thorough, and it's a great sample.
Thank you, Belinda. Elizabeth, what is the burden of disease in the U.S. for cervical cancer, and what is the current screening coverage?
So it's a good question. So I'm going to present some data from the US. I think what's interesting, I want to say it's actually Cervical Cancer Prevention Week right now in the UK. So it's a good time for us to be talking about this. And in the US, what we see is there's really wide disparity in terms of incidence. And this kind of it speaks to the fact that screening uptake and I suppose accessibility really varies across the state. So there is this wide difference in how people access care. And particularly in the South, there's much higher rates of cancer incidence. And when we then, sorry, it's a bit small, but when we look at this is looking at the incidence of cervical cancer by race in the US. This is data from the CDC. And we see that in ethnic minorities, so Blacks, American Indians, and Hispanic, there's a much higher incidence of cervical cancer. And Deborah on her first slide mentioned about the incidence in Black women. Actually, we see it's the 30% more likely to be diagnosed with cervical cancer. And actually, the mortality rate then is about 50% higher than in the white group. So there's really, really big differences. And it's important that we see if we can address these. I think what's really interesting, so in the UK, we actually have a national health system and a nationally organized call and recall cervical screening program. So that means women, all women are kind of invited for screening every 3 years, and they go in for a test. In the US, though, it's different. It's an opportunistic system. And what that means then is that you need to be part of actively engaged with the healthcare system in order to kind of hear from people that you need to come in for screening. And we saw, for the last 20 years, actually, the rates, the number of women who are being screened has really declined. So you can see it from the red line. Again, this is women's reported screening and engagement with the screening system, but it's really declining, and we're below what the targets are, which is 84% in the US. And actually, we're fast increasing. If this trend continues, we're going to hit the 70% target the WHO has set for screening. So we need to do something to address this issue that women are just not being screened, and this is going to cause a real increase in cervical cancer cases.
Elizabeth, given the declining screening coverage and the anticipated impact on cervical cancer outcomes, what do you know about the barriers to screening?
Yeah, so it's interesting. So again, if we look at what's going on in the US at the moment, so screening is recommended for women aged 21 to 64. And we think about this maybe splitting them into two different groups. So we have the women who have access to insurance, who are insured, which are the top lines, the darker lines. And then we have the women at the bottom who are uninsured. And it's about 8% of women are uninsured. Those women who are insured have regular access to GPs, so they can be screened through their OBGYN, places like Planned Parenthood. What we find with this group who are uninsured, the challenge is they don't have regular touch points with the healthcare system. There are still places for them to go, so they still can go to primary private centers, Planned Parenthood, and federally qualified health centers, but they will be paying out of pocket. So they can access it, but there's out-of-pocket payments, which might be a barrier for some. There is, though, however, free or very low-cost screening available, but the problem is a lot of people don't know about it. And just these are a few studies which we've identified. So again, if we look at this is barriers to screening across non-Hispanic whites, non-Hispanic Blacks, Hispanic. And the two dark lines on the left of each figure show that barriers to screening are this lack of insurance or a cost. So this is why women are reporting that they're not engaging. And I believe this is a study, I think it's from North Carolina. So this is in one setting. But if we then look at a much bigger study from across the US, we see a lot of people reporting the reasons why they're not going for screening is that they simply don't know that they should be screened. Nobody's recommending it to them because they don't have these regular touch points with healthcare providers, or they don't think it's an issue, or lack of access. So again, we're seeing this real relationship between people who either can't afford it or don't have access, and not knowing that it's a problem and not knowing that they should engage with services. And lastly, so we kind of talked about these barriers, but actually what's really interesting is a kind of approach like self-sampling using something like Colli-Pee device, you can actually overcome some of these barriers. So you could have self-collection kits in places where people do come into contact. So in outreach centers, for example, this would help with the issue of awareness. There's increased accessibility and acceptability because it's a non-invasive sample. And actually we've done some work, which I'm gonna talk about a bit, which shows that it could actually be cost effective. So we kind of get over that barrier of it being more expensive.
Belinda, give us your ideas of the barriers to implementation from patient and public involvement perspective.
Yes, thanks, Deborah, for this question. Actually, this actually specific question came at the back of a study that we did in UK in 2019. So we recruited 500 women, from which we gave the possibility to try several devices they could do at home, self-sampling. And then later on, I'll show you a bit more about the outcome of this study. But what I want to say here is that we had a massive press coverage at a conference that we attended showing the results. And this went into the press, national press in UK. And after that, I have been like inundated with email from women. So you can imagine for someone like me who is in the lab, I'm not in contact with any patient at any time. And at that time, I felt so overwhelmed by all these messages from women saying that they could not go to the clinic because they had trauma, because they feel that the pain, they can't have the test, it's very difficult for them to attend, or they were disabled. So they were thinking and they were telling me how important for them it would be to have this kind of screening tests made available at home. And COLIPI is one of the tests that could be done, and first of all, urine testing could be done at home. And also we had a lot of engagement with also the NHS, which is the National Health System in UK. And after that, they sort of started to create, to put in place a pilot to test this. So we still wait for the results, but we have actually more clinical trial in the UK that are coming up. So this is some of the results from the 500 women that were recruited, of which we gave the possibility to test several devices, self-collected vaginal devices, but also urine first void. So here you can see that we asked them the first question we wanted to ask them: how easy is it to use? Because you can't send a kit at home if the woman can't use it properly. So here you see with the first void urine, we had more than 60% of the women that said that it's very, very easy to use. And for us, that was a surprise in the first place, because we think, really? Because if you take the device, you're not sure that people will use it very well. So it was very reassuring to see that. And also then we asked them a second question, which was, are you confident that the result you will get from collecting the device at home will be good? And then this was even more overwhelming for us, because we had 69% of the women who said they were very satisfied and very confident with it, which is altogether 95% of the women who used the first void urine kit were very satisfied. Very good. So all these were very, very encouraging for us. So at the back of this, of course, we wanted to sort of set up new trials to just narrow down a little bit more what we are going to do, and do a DNA methylation test to triage HPV positive women, because this is a big issue. There are too many women at the moment in UK who come to colposcopy where they don't need. 40% of them will regress. So we wanted to establish new clinical trial using the COLIPI device. So in UK currently, we have several big trials ongoing, the Catch-up HPV for older women. These women are out of the screening program, but this is in this women group that we see the higher risk of cervical cancer. So we wanted to address this question, sending them a COLIPI kit at home. So this is ongoing at the moment, and we are going to recruit 10,000 women. And also, we are 2 other studies in UK, Predictor 5.2 this time. We're trying to pilot alongside the screening program that is in place. We're sending them a kit at home, a urine test kit at home, to do alongside the screening program to see the benefit of this. And then we have also a full program for low and medium income countries in Africa, particularly because for women who live with HIV, they are under-screened, they don't have access to any laboratories. So we wanted to see whether COLIPI will be, or the first void urine test will be a solution there. And so we have 3 different trials going on in Cameroon, in Ivory Coast, and also in Zimbabwe. And we really look forward to see the result, to really reduce inequalities in this group.
What have we learned, Elizabeth, from data models that you have developed and published, and how How could this help inform a U.S. strategy?
Yeah, it's a good question. So my team has actually done quite a lot of modeling, looking at different ways of implementing cervical screening in the UK, in Europe. We've done some in Canada, Africa. So really thinking about, within a given context and healthcare system, how do you use the tools available to make sure that you can have a workflow and kind of operationally put screening into practice. So this is actually work we published last year, my team did. And in the UK, we have an HPV primary cervical screening program, which means that, so in year one, you can see women would attend. So they're invited centrally, they're invited to go to a healthcare center. They would have a sample collected. This would be sent off to a central laboratory. You'd first do an HPV test, and anyone where there's a high-risk HPV detected, they would then reflex to cytology. And we heard a bit about the value of kind of reflex testing and triage testing in the session earlier. Those who are positive would be referred on to colposcopy for further investigations, and those negative would then come back in year 2 and then potentially in year 3. So this is what's happening in the UK. And what we then did was say, okay, well, if we were to then use something like Colli-Pee to be able to do urine sampling, self-collected urine sample, what would this look like? So we created this model which looked at women collecting the Colli-Pee, using Colli-Pee to collect urine, sending it off to the lab. This would then be tested for HPV. In the model, because of the currently you wouldn't be able to test it on cytology, those who are positive for high-risk HPV would need to go back to the clinic to have a sample for cytology. And then if they're positive again, go to colposcopy. Those who had a discrepant result would then be referred again for year 2. So we looked at how this would work in England. And again, it's really important to say, this is within the English context, but this could be very relevant to places like the US or other settings as well. So what do we find? So the panel on the left shows the total cost of delivering this. And again, we heard about the importance of looking at the health economics of implementing this technology. So this is looking at the total screening and testing costs for women under either clinician-collected samples in purple, first void urine in the light blue in the middle, and vaginal self-collection on the right. What we found is actually if you use first void urine, you would have the least cost. So quite a big reduction actually from clinician collected. So it goes from about almost $450,000 down to $322,000. So a big reduction. And interestingly, we don't see any real reduction in the number of complete screens. So this means we're still reaching the women. We're still able to capture that group, even though, as I mentioned, they would need to come back to the clinic for another sample taken if they were HPV positive. We're still seeing a really kind of effective screening strategy. And then on the right, it shows the cost per complete screen. And there's a really big reduction. So in the UK setting, and in the English setting, I should say, we found this is to be cost effective. So this is definitely a viable way of delivering screening within this population. And I think, there's a few things that kind of resulted from this. What's interesting is we always hear when we implement new technologies or new ways, people say, oh, it's going to be too expensive. The acquisition cost of the test or whatnot is too expensive. And actually, if you think about the whole kind of continuum of care from the diagnostic pathway, it's not. And in this case, cost is not a barrier. So we could use this as a viable option within certainly the English screening program. But as I mentioned, it's important to think about how do you actually implement this into practice. And so you do need to think about what's the pathway? How am I going to implement it? Things like making sure you have lab automation is really important to keep your costs down and make sure that you can have a good kind of throughput. Thinking about your target population, screening uptake, all of these factors will influence your kind of cost effectiveness and health economic results. So it's really important you think about what population are you doing it on. But, we concluded that first void urine collection could give greater access as well. So again, we talked about at the beginning, Belinda mentioned, a lot of her results showing that this is a barrier. So people aren't going. So if we used it, we might be able to increase access. And at the end, people say, well, could this work in the US? And I think it could, but we really do need to do that work, right? We need to understand within the US setting or any other setting, what would it look like? So it is really important to work with people to find that out.
You've both done great research that certainly will be a pathway to what we're doing in the United States. Belinda, as an expert in the field, Could you give us an example of a clinical trial that demonstrated the utility of first void urine for cervical cancer detection and its translation to the U.S. setting?
Yes, thank you, Deborah. So this is a little bit what I'm going to show here is on the screen there is a study that we performed in UK that I just, alluded about like a few minutes ago. This is what we call the 5.1 predictor study. So here we recruited 600 women who were either HPV positive or had actually an abnormal cell. Detected with an abnormal cell. So we offered them the possibility to use 2 vaginal devices and a Colli-P urine, which is a first void urine. And what we did, we tested HPV DNA testing, and also we tested the DNA methylation test that we developed in my lab. So the first question we were asking when we had the sample in our hands, like any scientist working in the lab, is like, what is the quality of the urine sample versus the other self-collected vaginal sample? Right. Is this better, worse, or things like that? So actually what we saw is like the first void urine gave us a very good quality here that you can see in the graph there. So compared to a vaginal sample that was then put into preservative media and a vaginal sample that was actually collected dry. So what we can see here is the first void urine give us a very good quality, and specifically I think is certainly due to the preservative that there is there, which is a very adequate for what we're trying to test in the lab. So that's the first step. The quality, yes, we tick the box, but the second step is okay. So the quality is good, the DNA is preserved, but can we perform the test? And what is the performance of the HPV DNA test in the first instance? So here, what we looked at, especially for the first void urine, which is the bottom in this actually table here, we looked at the performance of the DNA HPV test to detect CIN2. So CIN2 is a pre-cancer lesion, grade 2, and CIN3, which is pre-cancer lesion, grade 3. And as you can see here, we had a very good sensitivity for the detection of CIN2 with, for instance, 82%, which was a very good level for sensitivity, and 89% when we look at CIN3. So we were very happy to see this result, which comforted to perform more analysis.
For both of you as experts in the field, what are your recommendations for next steps?
So, first of all, my recommendation for the next step particularly, I'm very interested now not only to bring a new technology with the DNA methylation test, right? So this is very important and useful, but you need to bring this technology to the women. So you need to increase the coverage. You need to access the women who are the most at need. You need to stop asking them to come if the HPV positivity is going to clear. So therefore, what I'd like to see a bit more is a bit more an integrated pathway where you take care of not only the DNA test or the test you offer, but also the women, the behavior, are they going to come, not come, but also the cost effectiveness of it. At the moment, we are working in silo, not so much actually now with Elizabeth and Deborah. We're trying to bring all these matters together because it's very important. I think by offering a self-sampling, whether it's a urine one or self-collected vaginal one, because everyone have their preferences, you can increase certainly the screening compliance. People maybe will come more. Therefore, you increase the coverage. And if you increase the coverage, you increase the capacity of picking one cervical cancer. Absolutely. And in addition of this, you offer a sort of autonomy to the women and have more privacy, especially for the one who are disabled, who had a really big trauma in their life. You wouldn't know that actually. And cost effectiveness, because Elizabeth showed that actually is very cost effective, and I'm going to let her speak a little bit more about that.
Thanks. Yeah, so I kind of come back to this point because I think it's really important, especially if we're thinking about the US context. We do have, for those who are insured, they're having their touch points, they're seeing people, they're being recommended screening opportunistically. It's really this group at the bottom that we want to really do something about in terms of increasing access and coverage. So it's this uninsured group. So I think new technologies and new modalities for collecting samples, such as using urine, can be really beneficial. And I suppose what's interesting, we've actually done a lot of work across all sorts of different cancers and diseases, and we've seen this not just with things like cervical cancer, but we've seen it with, for example, offering tests for bladder cancer or prostate. That using different samples such as urine can be non-invasive and can actually potentially increase coverage. So the work that we're talking about today is a really good case study of how it applies to cervical cancer, but this could apply to lots of different areas. And I think also, having gone to quite a few talks and speaking to people here, there's so many amazing organizations presenting and displaying here who have really great technologies, and I think we need to think a lot more around how can we think about integrating this great tech into pathways using different sample collections, so using urine or even blood, using blood rather than taking biopsies, for example. So I think there's a real opportunity to think about that. And I think how do you integrate it into the pathways is really important. And everyone's going to ask about, well, is it cost effective or what's it going to cost? So, you need to look at that part of it in order to develop the evidence to make a case for decision makers. I think in cervical cancer, there's already a really good evidence that, we can do it, but we need to kind of overcome this last hurdle of really, finding these women and getting them screened.
Thank you. We have a real problem in the United States around this issue. And we've heard today that these two researchers especially have done the type of research that give us a pathway to what we need to do next. And we're doing this panel today because we respect you and we respect your knowledge. And we ask for your help to help us figure out and you to figure out and join us in coming up with some solutions. We have a tool, one tool in this particular area. But we know that your use of this tool, your involvement of this tool in your research, you're putting some of these other things forward and making this move in the way that it needs to move will be a trajectory for women whose lives need to be saved. So we ask you to please feel free to join us in booth C941, 941. We're asking you to come share with us what your thoughts are. We'd love to talk to you. We're getting ready to get up and go over there now. I want to point out Juan, who's in the audience, who's a colleague from OraSure. Grab him, ask him whatever you need to ask him. He's an expert in this area, and we want to thank you very, very much for joining us this day. And we hope that this day and the things that we've said and the things that we've laid out will help you move forward and what needs to be done to help save the lives of these women. Thank you very much.